Welcome to this web learning session on complicated bacterial lung infections, where we'll discuss the mainstays of lung abscesses and pleural empyema, including diagnosis, microbiology, and treatment. The lung abscess and the pleural empyema represent two different entities of severe bacterial lung infections. There are similarities and there are differences which we are going to discuss in the following, starting with discussing the lung abscess. A lung abscess is defined as a well-defined necrotic lung infection where we see loss of healthy lung tissue and the appearance of one or more cavities on basically on a CT scan or an X-ray. They can be subdivided into primary lung abscesses, which occurs from a necrotizing pneumonia or due to aspiration or opportunistic infections, and the secondary lung abscesses, which are lung abscesses that occur in relation to either a tumor or an aspirated foreign body, and also lung abscesses in severely immunocompromised patients can be seen as a form of secondary lung abscesses. Key symptoms with lung abscesses include long-term fever and cough for a long time, even for weeks or months, and also symptoms of weight loss, chest pain, and bad smell from the mouth. Now, these symptoms are obviously not specific for lung abscesses and could lead our thoughts towards lung cancer and in risk groups and in some part of the world also on tuberculosis. And truly, we do diagnose lung abscesses in programs aiming to investigate for lung cancer. Pathogenically, a lung abscess is a necrotizing infection, and it's most often due to polymicrobial flora that would include anaerobic as well as aerobic bacteria. Actually, it's most often due to aspiration of polymicrobial flora either from the mouth or the gastrointestinal tract. But it can also arise due to necrosis during a severe pneumonia. Now, at least one previous study have demonstrated that episodes with reduced consciousness could be seen in up to 80% of cases with lung abscess, pointing at the importance of aspiration during episodes of reduced consciousness. And in keeping with this, diseases with dysmortality and swallowing dysfunction and neurological diseases are risk factors for lung abscess, as are alcohol abuse. Lung abscesses can also be seen as monomicrobial abscesses that can be metastatic spread from endocarditis, and that is most often in the form of multiple monomicrobial abscesses. The radiological appearance of lung abscesses is in the form of one or more well-defined cavities within the lungs. And the cavity most often includes fluid and air and can lead to a fluid surface within the cavity. Now, a hallmark of the lung abscess is that it tends to invade surrounding lung tissue, bronchi, and also vessels, and that is in contrast to the empyema that would normally displace these structures. Especially when an abscess is located close to the pleura, it can be difficult to differentiate an abscess from an empyema. Generally, the abscess has an equal shape in different projections. That means generally they are round or roundish, while the empyema appears different in different projections and are generally lentiform in structure. The abscess is most often surrounded by lung tissue, where the empyema is surrounded by pleura, and there would be no lung tissue on the lateral side of an empyema. Abscesses tends to invade bronchi, lung tissue, and also blood vessels, while the empyema tend to displace these structures as it is located within the pleura. Abscesses generally would have a thick and irregular wall, and generally speaking, an empyema has a more thin and uniform wall. Now, if the abscess is located in relation to pleura, it would form an acute angle between the pleura and the abscess cavity, while an obtuse angle would form from the lentiform empyema and the adjacent pleura, as is demonstrated here, where we see the abscess structure forming an acute angle and the lentiform empyema forming a more obtuse angle with the adjacent pleura. As with most infections, microbiological sampling should preferably be performed before the initiation of antibiotic treatment. That said, microbiology of lung abscesses is most often polymicrobial, and it's difficult to obtain good results on conventional cultures, as many of these bacteria would not grow on conventional media. Now, in studies reporting on microbiological finding, the results vary with geography and also over time in older and more recent studies, and also with the sampling method, probably partly because of contamination of some samples, especially expectorate sputum samples that would differ from bronchoalveolar lavage results and the transtracheal aspiration that was more commonly used in older studies. But when pathogenic bacterial species are found, the most commonly recovered species are staphylococci and pneumococci, and also Haemophilus, as well as species like Prevotella and Fusobacterium and Streptococcus. Treatment of lung abscesses is based on long-term antibiotic treatment, most often for 4 to 8 weeks, depending on the response and on the extent of the abscess. There is actually sparse evidence regarding the antibiotic strategy and also the duration of treatment. What we do know is that early studies using either penicillin or metronidazole as monotherapy had very bad results, and therefore we should ensure coverage for gram-positive and for anaerobes in our treatment regimens. There is reasonable evidence for empiric use of clindamycin or moxifloxacin, and also for the use of the combination of beta-lactam antibiotics with beta-lactamase inhibitors, for example, piperacillin and tazobactam. So, empiric treatment regimens could include a beta-lactam with a beta-lactam inhibitor, either piperacillin and tazobactam, or amoxicillin with clavulanic acid, or clindamycin, or the combination of penicillin and metronidazole, as is here shown in a Danish article regarding lung abscesses. So, should we use percutaneous or transthoracic drainage of lung abscesses? Well, that has been discussed for decades. There is one meta-analysis dealing with this question from 2012. And as we see, the studies including in the meta-analysis are generally very small, which is a thing with most studies on lung abscesses. They do found, however, a fairly good success rate with the use of percutaneous tube drainage. And drainage should probably be considered in select cases with very large abscesses or abscesses close to the pleura. The general fear with percutaneous drainage is the formation of fistula, but that risk is probably smaller with the use of effective antibiotics. There are few studies on outcomes and mortality regarding lung abscess, but basically in hospital all-cause mortality have been seen up to 20%. In this study from 1999, they found that the recovery of bacterial species correlated to mortality, and especially while the recovery of pneumococci or Haemophilus was associated with a fairly good prognosis. The recovery of anaerobes, including Pseudomonas and Klebsiella, was associated with very bad outcomes, and also the number of predisposing factors to lung abscess was associated with the in-hospital mortality. Follow-up after treatment for lung abscesses should generally include imaging after treatment after 4 to 8 weeks. Either CT or in some cases X-ray might be enough. And also, as we know that poor dental status is a major risk factor for lung abscess, it is generally recommended to consider dental follow-up for patients with lung abscesses. And always the risk of underlying malignancy should be considered, especially if treatment is non-successful. So, to sum up some conclusions regarding lung abscesses. Lung abscesses is necrotizing lung infection, and it's characterized by the occurrence of one or more well-defined cavities, most often with the fluid surface within the cavity that includes fluid and air. And risk factors for abscesses include the use of sedatives, poor dental status, and neurologic disorders. And as we saw, episodes of reduced consciousness can be identified retrospectively in a large number of patients with lung abscesses. Secondary abscesses can arise due to lung cancer, the aspiration of foreign bodies, or in a case of severe immunocompromisation. Treatment is based on antibiotic treatment, long-term treatment, but thoracic drainage is an option in selected cases, especially with larger abscesses and abscesses close to the chest wall. Follow-up should include imaging, and it's important to consider the risk of underlying malignancy in all cases of lung abscesses. Contrary to the lung abscess that occurs within the lung tissue, a consolidating infection within the pleural cavity is termed a pleural empyema. And we're going to discuss that in further detail. Infections of the pleura is a spectrum from simple parapneumonic effusions with a clear fluid in the pleura over complicated parapneumonic effusions with clear or cloudy pleural fluid with high cell numbers and reduced pH, and towards a frank empyema, which is defined by the occurrence of pus in the pleura. And this presentation on the empyema will actually cover complicated parapneumonic effusions and the true empyema, where the treatment options are equal and which represents a spectrum of infections. A pleural empyema most often occurs from a secondary directly spread of bacteria from a severe pneumonia to the pleural space. Other causes may include trauma and perforation of the esophagus, where empyema can inform adjacent to the mediastinum, spreading from bacteremia or invasive procedures or thoracic surgery. Cultures for bacteria are positive in generally less than 50% of cases for the same reasons as we discussed with the abscesses. When we do recover bacteria, it's most often streptococci, staphylococci, and also gram-negatives and anaerobes in a polymicrobial infection. The diagnosis of an empyema relies on radiology. That could be X-ray or CT or ultrasound, as we will cover in a short while, and then evidence for infection, including blue leukocyte counts and CRP and so on. The diagnostic process should include microbiological examination of blood cultures, of pleural fluid, and of sputum, and then a thoracic ultrasound and ultrasound-guided pleurocentesis is in the center of diagnosing pleural empyema. Ultrasound is superior to CT in diagnosing a septate effusion and also in estimating the effusion volume, and is a prerequisite for pleural drainage. Pleurocentesis should be performed in all cases of empyema, and samples should be sent for microbiological examination, including culture, and then if antibiotics have been started and have been carried out for more than 1 day before pleurocentesis, it should be considered to do more advanced examinations, including 16S PCR on the initial samples. Supplemental analysis are performed, including pleural fluid pH, glucose, LDH, and thoracic ultrasound is superior to CT in diagnosing septate effusions and also in estimating the fluid volume. As we see here, thoracic ultrasound, where we see the pleural line on top and the diaphragm in the bottom, and in between we have a septated effusion with multiloculated pockets of pleural fluid. It gives us the opportunity to investigate the empyema or the pleural fluid in more detail than a CT scan does, and it is a prerequisite for drainage of the effusion. The treatment strategy starts with identifying a pleural effusion and demonstrating a suspected infection. And the first step is ultrasound and drainage of the effusion. If it shows out to be a simple pneumonic effusion, treatment is antibiotics and a chest tube, and the chest tube can be removed as soon as the effusion is fully drained. If there is evidence for a complicated pneumonic effusion or a frank empyema, treatment should include antibiotics and continued drainage. In most cases also intrapleural lavage, and depending on the severity and the complexity of the effusion or the empyema, we should consider administering intrapleural treatment as well. And then we need to reassess our patients, and generally we treat for 48 hours and reassess, and we do that in order to identify patients who need to step up treatment or go to second line treatment, including surgery early in the process. So the reassessment of the patient with the empyema includes the question of whether the patient is improving, and that includes clinical improvement, radiological improvement, and also improvement in lab values, including falling CRP values. If the patient is improving, we should continue and reassess again after 48 hours. The chest tube can be removed when the production of pleural fluid ceases, but the antibiotics should be continued in most cases for 4 to 6 or even 8 weeks. If the patient is not improving, we should consider scaling up treatment using intrapleural therapy, and also to go to a secondary CT scan, and the patient should then be discussed with a thoracic surgeon in order to identify patients who need surgical treatments timely enough. We're going to discuss the intrapleural therapy and the second-line treatments. Intrapleural therapy can be used as an adjunct to tube drainage and to antibiotics. And historically, streptokinase, urokinase have been used, and nowadays alteplase, which is a fibrinolytic that is also used in thrombolysis of apoplexia, is the most common strategy. Alteplase can be supplemented by DNase, for example, Dornase alpha with the trade name Pulmonale. And the typical regimen includes administering 10 milligrams of alteplase every 12 hours for 3 days, and that's administered in the catheter that is closed for 1 to 2 hours in order for the treatment to stay in the pleural cavity. If it's supplemented by Dornase alpha, by DNase, that should be performed 1 to 2 hours after alteplase, and also be continued for 3 days. But do check your local guidelines. Reassessment should be performed after 3 days of treatment, but also, of course, if the patient is deteriorating during treatment. Contraindications for alteplase, which is a fibrinolytic, is severe bleeding episodes, recent surgery, and apoplexia. Surgical treatment options for empyema includes more advanced drainage options, including insertion of additional drains and separated empyema pockets, and also the insertion of large bore catheters that allows for more efficient drainage of more complicated and septated empyema. Surgery as such is the key second-line option in case of lack of improvement or deterioration during first-line treatment. And surgery includes video-assisted thoracic surgery as the first choice and open thoracotomy as the second choice. Now, we will not discuss surgical options in more detail here and surgical techniques, as it lies beyond the scope of this presentation. Antibiotic treatment as an adjunct to drainage is the key of treating pleural empyema. And initial intravenous antibiotics is generally applied, followed by an oral consolidating regimen for a duration of 4 to 6 or even up to 8 weeks. Regimens are generally based on local recommendations, and the evidence for specific empirical regimens is sparse, but the rationale is the same as for lung abscesses, including coverage for gram-positives and for anaerobes, as infections are often. The prognosis in patients with pleural empyema can be assessed using the RAPID score, which was first described in 2014. And the RAPID score includes renal function, age, the appearance of the pleural fluid, whether it's purulent or non-purulent, the source of infection being either community acquired or hospital acquired, and then a dietary factors in the form of serum albumin, and that yields a score from 0 to 7, dividing the patients in separate risk groups. And from the same data here, the authors found that low-risk empyema had a 3-month mortality of 1.5% and ranging up to 48% mortality in patients with high-risk empyema with a rapid score of 5 to 7. So, to conclude on the pleural empyema. Pleural empyema is diagnosed using CT ultrasound and analysis of pleural fluid. It's basically a continuum from simple parapneumonic effusion and overcomplicated parapneumonic effusions to the frank empyema. The mainstay of the true empyema is the recovery of pus from the pleural cavity. Treatment consists of drainage and antibiotics, and intrapleural treatment should be considered individual. Second line treatment is thoracic surgery in the form of VATS as the preferred method, or thoracotomy. The risk of complications from pleural empyema is high, and the prognosis can be estimated using the rapid score.